The first topic is how we manage patients diagnosed with oral cancer. I would imagine that this is something that most of you deal with at your respective institution and countries. Equally, also would imagine that maybe some differences in how we approach it versus how you approach it. But nonetheless, I think more likely than not, the common thread will be the same. When we think about oral cancer patients, we have to think about sort of a stepwise management. And when you think about things, typically you think about how the patients present clinically, how you're going to work up the patient, how you're going to stage the patient, and then deciding whether or not you're going to manage them surgically or you're going to manage them else with a different modality. And if you do manage them surgically, which patients should be treated with adjuvant therapy post-operative? So using that as a background, that's what I'm going to use in order to kind of delineate the lecture. So if you look at statistics, and unfortunately, this is when giving a lecture to such a broad audience, it's difficult to find country-specific. So I'm going to use the statistics from the United States. This is published every year by the Cancer Journal of Clinical Oncology, and this was published at the beginning of the year. So if you look at the cancer statistics for 2022, obviously this is in retrospect for the previous data, you can see that the oral cavity cancer in particular is not a very high burden in the United States. It does account for nearly 54,000 cases per year. And of those patients, if you look who is in terms of gender, it typically tends to be over double more prevalent in males as opposed to females. And then equally more important, when you look in terms of site, you can see that there's some differences. You know, historically, we would say that the tongue was far more prevalent than other sites, but you can see that now the numbers are beginning to shift with the oropharynx increasing and getting beyond that of the tongue itself. And that has to do with the increasing incidence of oropharyngeal cancer, and we'll talk about that shortly. When you look at deaths, that is also an important statistics to look at, and you can see that remains a problem. Now, of the top 10 cancers that affect both sex, males and females, oral cavity for males does make the top 10. It's number 7. Which that in itself is a problem. In females, it does not make the top 10. But thankfully, when you look in terms of death from those, neither males nor females head and neck accounts for those for the top 10. So you typically see these other malignancies affecting other sites. Although you can say that esophageal malignancy can be at times, depending on the location, potentially within the head and neck site. So when we look in terms of the distribution of how patients present and the survival rate based on the presentation and race, you can see that there's some work to be done. That remains the same problem, particularly with African Americans or patients of African descent having diagnosed with more advanced disease, and therefore that translating to a poorer outcome altogether. You also see that in terms of the distant disease, that also tends to be a problem. I think there is some good statistics for us to keep in mind, and that is in terms of both the incidence and in terms of the mortality. If you look at this graph, you can see that the incidence is trending down, both for overall incidence and gender specific. You can see that the males continue to go downwards, although there's a slight raise in the female. But towards the end of this data set, you can see that there's beginning to be a downturn. More importantly, or equally as important, is the fact that Somehow we've become a bit better in terms of managing these patients. So you see that the mortality overall for both, as well as gender specific, is trending downwards. And that is something that was noticed in the late 90s, and that continues to be the case today. When you look in terms of cancer specific, looking both head and neck and how we fare with the others, you can see the same thing in terms of that it's either not present, or if it is, that it's downward trending. This is the publication, and now a bit older, but if you look at the overall survival, that we are doing much better. In the 60s, if a patient was diagnosed with oral malignancy, less than half of them will be around 5 years later. In the late 2020s, 2010s, that had significantly increased to the 60s, 63, and then that continues to be upwards. So I think overall, both a combination of the surgical intervention and adjuvant therapy, whether it's radiotherapy or chemotherapy, and I think we all are aware of some of the advances in terms of immunotherapy, that all of these things have become increased in terms of the armamentarium that we can use to help our patients. The risk remains the same. We know that if you smoke, particularly if you're a heavy smoker, greater than 30 pack per year, that significantly increases your risk odds ratio of having oral cancer. And if you do more than 60 pack a year history, that's 23 times that of the standard population. So a significant risk. Now, what if you were able to convince your patients to stop smoking? That is something that is important, because you see that if you stop smoking as early as between 1 to 4 years, your risk reduction goes down significantly by 30%. And if you stop smoking anywhere between 10 to 15 years, it goes down to 60% for the laryngeal cancer. So all of this important things to keep in mind when we see patients, to kind of counsel them, if at all possible, to stop smoking. So smoking cessation should be a part of our discussion with our patients. Alcohol, again, we know that that becomes a problem, specifically if you do the combination of the two. An interesting thing to think about is also there's a gender dependence. Female consumption of greater than 30 grams of alcohol per day increases the relative risk of head and neck to 29. And then to give you a context, 10 grams of alcohol is basically one drink. So if you consume three beers per day, that increases your risk significantly. Also, if you compare, as we did with smoking, alcohol consumption, even if you stop, you don't observe any benefit only until about 20 years post. So if you're a significant alcohol consumption, it does take quite a bit of time for your risk to reduce to that of standard non-drinking population. Other factors that are important, if you do smokeless tobacco, which is a bit more common in the United States, particularly in the south of the United States. And I put here an athlete, a baseball player. For some reason, baseball players had a history of using this, albeit now that has been tackled and that has decreased significantly. And in some of your countries, also the use of Biddlequid, that becomes an important risk factor, particularly for buccal squamous cell carcinomas. And I think you all are aware, some of the differences, how we call it. In the Sudan, I believe it's called tumbak. And then so if some of the patients are using this, and based on the location where they put this in the mouth, that can have an effect. And then you may see the same in terms of location of buccal squame for these patients. Now, for the past 20 years, we've seen the role of HPV in terms of head and neck malignancies, particularly oropharyngeal malignancy. And we know that has become a significant problem, and that is has changed the diagnosis and changed sort of patient demographics significantly. And we know that there's an association with sexual behavior and the probability of acquiring this, and that is directly correlated with the number of passionate kissing partners, oral sex, and so on, and the number of sex partners that you've had over a period of time. And this is some of the statistics that look in terms of lifetime number of partners, and then the associated risks of getting oropharyngeal carcinoma. So if you've had more than 8 partners lifetime, your risk of getting oropharyngeal carcinoma is significant. It's 43% in terms of like the numbers in this study, because they had 25 patients that fell within that category. So where does that located? HPV tends again to be more of an oropharyngeal issue, as you can see here towards the behind the retromandibular region, retromolar pad region, and you can see that, and that it becomes important in terms of our clinical inspection and how we manage the patient. The good thing about, if there is a good thing, I think is that for this particular class of patients, we do see a good response, particularly radiotherapy, and that you can see again in terms of the trend, although oral cavity is trending down, oropharyngeal is trending up, and we talked about this a little bit before. But the survival rate, patients with oropharyngeal cancer that are HPV positive tend to be significantly higher than those that are HPV negative, taking into account the smoking background, which sometimes if you're a smoker, it potentially negates that benefit. So how do patients present? Again, the presentation may be subtle, such as in this patient with a junction between the tongue and the floor of the mouth that you can see there. Sometimes they may have had a biopsy or may have had an incision at the referring physician. And so when they present to you, you have an ill-defined area. Sometimes you may just have a scar, so early presentation. But the more common is this, at least in my practice, patients that present with advanced disease, as you can see in this patient, it's pretty evident. Now, there's lots of reasons why they present late. Maybe sometimes it's because of access to care. Sometimes it may be that they're being managed as an infection. There are all sorts of different things, different reasons why patients present late. Again, multiple examples, whether independent of location. I think oropharynx, sometimes because of the location, it tends to be missed, particularly by the dental profession as opposed to the medical profession, and the converse is true. The oral cavity sometimes is missed by the medical profession and picked up more by the dental profession. If patients do present with nodal disease, that is significant in terms of overall survival, as we all know, and they may present with early disease or late disease, as you can see here. Some patients with an N3 node, and some patients, again, with N3 significant disease. All of these become important in terms of how we diagnose or how we decide who are the patients who will be candidates for intervention. And we do that more often through imaging, and that may be different based on the locations. In the United States, the trend is to use CT scan with contrast. Other countries may use ultrasound or MRI. I will go quickly through this section. But it's related to the size. So if you look in terms of what pretends to be a nodal disease, level 1 and level 2, any node that is greater than 15 millimeters, retropharyngeal nodes greater than 8, and all others greater than a centimeter. What are the important things that you look on imaging? Obviously, it's the configuration. If you see loss of the fatty hilum, the homogeneity of the node, does it enhance how the borders look like? Do you still see the surrounding fat planes? And using those things, then you can look and decide based on the level of the neck. And Peter Sommer is the one that had described this. We are quite aware that the levels 1 through 4 and 5 in some cases are the most important relative to oral malignancy. And there are divisions based on each nodal level. Level 1 is above the hyoid and anterior to the submandibular gland. And typically you see things like this. These are axial scans with contrast. You can see nodes that meet that criteria for concern for metastatic disease. Again, the level 1 can be subdivided into submental 1A and submandibular 1B, as depicted here. Level 2, again, depicted as you can see here. I'll go through this quickly for the sake of time. What is important to keep in mind, whether irrespective of the level, what constitutes something that we need to worry about. And at the end, when you evaluate the scans, what you want to think about is that in terms of comparing clinical sensitivity versus imaging, sensitivity by palpation is only about 65% and the accuracy about 75%. When we couple that with imaging, that significantly increases to the 80s, but it's still something that we may miss up to 15%, and that's why nodal dissection becomes important. And it's important that to keep in mind that even with this, even after pathologic examination, you may miss an overall 3% of disease. So what constitutes a node that may be concerning other than those things that we talked about? If you see the shape that is rounded, if you see the enhancement patterns, if you see clustering of nodes greater than 3 contiguous nodes, the confluent about 8 to 9 millimeters, if you see necrosis, if the borders are effaced or it's consistent with extra capsular spread, all of those things become important in terms of how we decide how to proceed. So if you see patients with multiple disease or concerning for nodal metastasis, the next thing that we do is we obtain a PET scan, and the PET scan is the positron emission tomography. As you know, this is a tracer that mimics the glucose. However, it's tagged with a fluoride that one is able to see, and then you can get this standard uptake value. So based on the SUV, it can be more consistent with suggesting of malignancy versus an inflammatory process. And typically we use this cutoff about 2.5, but again, you have to take it within the context. So the higher the SUV, the higher the probability that what you're seeing is in fact a malignancy as opposed to an inflammatory process. Now, it is routine to couple the PET with a CT. So you have a PET CT, which gives you more anatomical information, as you can see here. And that allows you then to have that discussion with the patient, as also within your tumor board, as to decide who is a surgical candidate and who may be a candidate for adjuvant therapy. The usefulness of PET scans or PET MRI is, I think, is pretty evident. You can see here examples of such and how it benefits us in terms of the deciding, particularly in the patients that have had treatment before, to decide which one is an active node, which one is a dead node, and which one do you need to go and seek. In terms of staging, the only thing that I would touch upon is the fact that since 2018, the depth of invasion now plays a role in terms of what a T1 is. It's less than 5 millimeters, but consistent again with the previous diagnosis or the previous staging, less than 2 centimeters. If you have a depth of invasion between 5 and 10, that is a T2, and greater than 10 is a T3. Those are things that we have to keep in mind. In terms of nodal disease, the N2 or pathologic N2, it looks at nodes less than 3 with extranodal extension, and as you can see, the rest. Now, the surgical management, I think, which is what we all really think about, is deciding, okay, we're going to do a surgical intervention, and how we're going to get to it in terms of the resection, what access are we going to use. In terms of access, we have multiple, and it's largely dependent on in location as well as the tumor staging. The larger ones, you may have to have a transcutaneous incision. If it's located within the oral tongue with a movable tongue, you can do a transoral resection, as you can see here, and you have primary closure, and then you couple that with your neck dissection. And we'll talk a little bit about that, because neck dissection later on, and then you can have access for your reconstruction, as you can see here. You can do margiomandibulectomy through a transoral, again depicted here. Sometimes you may have to do a transcutaneous access. In terms of the mandibulotomy, you can do with or without lip splitting. If you do with the lip splitting, we know there are lots of ways that one can go about that, whether you do a Trotter approach, whether you do McGregor, and so on. And then once you reach the bone, you have to make a decision: do you do a straight cut or do you do a step ladder? The rationale for doing these steps is they increase bony contact to improve on healing. The typical approach is, as you can see here, I no longer do this the mental curvature like that. I go straight through as in the Trotter approach. Exposure, plating, access, and then you can see the tumor, so they can have the resection and ensure that you have a better visualization, and so that you can take proper margins. Again, depicting here, your typical approach allows you to expose better, allows you to do these hemimandibular resection, a compartment resection, again, all within with the idea that you're able to have access, visualization is improved, and therefore your probability of getting a better margin and better resection is therefore equally improved. You can do a Weiser's approach. Obviously, in these cases, you sacrifice the mental vessels, but it allows you to carry out the resection, as you can see here. Segmental resection can be done transcervically without splitting. You can also deliver the tongue into the neck, as you can see here, and then carry out the resection without splitting the lip and without doing a mandibulotomy. So all of the combinations largely dependent on the location of the disease, as well as the extent of the disease. Maxillectomy, the tumor is located in the midface. We are all aware in terms of how we can approach. If the tumor is extending towards the anterior maxillary wall, then we typically do a Weber-Ferguson, as you can see here, so that we can visualize that anterior component a little bit better. If it's extending posteriorly, I think still a lower lip split allows you to carry out that resection better. And if it's transgressing both, then an open book allows you to do those things. Depending on the location, there are different ways that we can approach it, but all within the goal of diminishing the morbidity for the patient. So that also brings about the use of robotics, again, with the idea of diminishing access and the morbidity. It allows you to use these long instruments to have access. Typically, we'd use this for pharyngeal carcinoma. You can see here, this is the robot docked. Obviously, now we have a single port robot, so that it's a much easier process as opposed to this with multiple ports. The way that we set this up is that, once we dock the robot, as you can see here on this, then the surgeon goes and sits in the console, and then you can carry out the resection robotically, as you can see here, and you can do the surgical intervention within the oropharynx, so sites where it's a little bit more difficult to get to. without having to do, again, these big access, and allows you to resect the tumor. And you can also carry out the reconstruction, the suturing with the robotic. As it relates to neck dissection, who needs to have a neck dissection? We know that nodal disease is important to ascertain because it translates to a overall diminishing in terms of survival. And we know that if you have a single node, it diminishes your overall survival by 50%. If it's a contralateral, by another 50, and so on. So it's important for us to ascertain the status of the nodes. So if you look here, this is a study that was done many years ago at the Memorial Sloan Kettering. You can see that tumors that are 3 millimeters and above have significant probability of nodal disease. And you can see here increases from those less than 2 millimeters from 7% to 26%, and that's why we do a nodal interrogation with neck dissection, whether you do a therapeutic versus a staging neck. When you look in terms of the patterns of the location of nodal disease, we know from the oral cavity, they tend to be on the higher levels, so level 1 and 2. The vast majority and the nodes are located within the site, and as you go down further to level 4, the probability of having nodal disease there is less than 10%, which then dictates that most of the time you don't have to go to level 4, and seldom do we have to go ever to level 5 to do a neck dissection. In the past, there used to be lots of nomenclature for neck dissection, as you can see here, and that was found to be quite confusing. And Katie Robbins and others, nearly now 20 years ago, consolidated this to simply calling it a selective neck dissection, and then using the descriptors to what levels you dissected. So selective 1 to 3, selective 1 to 4, which is far better than all the different permutations of that existed before. In terms of how we access the neck, again, the incision varies, and it's often surgeon preference. Now, rather than doing an apron, as you can see here, I typically would just do a transcervical crease incision and without having those vertical limbs. And I think that heals far better for the patient, and it's aesthetically much better. When I was training, the modified Schobinger was common, particularly for those patients that had a radical neck dissection. Also, we used to do McPhee incisions for the patients that we did a selective, and that is no longer the case, at least not in my practice. Now, who needs what? Thankfully, very few patients, at least in my practice, need radical neck dissection. And we know what that entails, taking all 5 nodal levels, as well as the structures, both the muscle and the vein, as well as the nerve. The contraindication for neck dissection, there's some variability in this, but carotid encasement, that is in itself not necessarily contraindication. We've published on this where you can potentially change a T4B back to a T4A. We can discuss this in the Q&A. And then in terms of how you do the neck dissection, or which patients need a radical neck dissection, it's the typical one with an N3 disease, or patients with multiple nodes. And then you can see here again, this is things that we do pretty routinely. The extended neck dissection is anytime that you're doing those things that we talked about, but you're taking in addition to that something else. And typically that involves the skin. Those patients put into the extended neck dissection. Again, some case examples. In terms of modified neck dissection, again, it's whenever you preserve one or more of these structures. I'll go through this rather quickly for the sake of time. But we all know in terms of what the essence of neck dissection is, that you want to remove all the fibrofatty tissue such that you have a patient that ends up with all the structures left behind. As you can see here in these imagings, that you now have a really thorough neck dissection. All the fibrofatty tissues are removed, all the lymph nodes are removed, and then you have all the important structures left behind. This is important because it then is a good segue in terms of your reconstruction. I'm going to skip this. When you look at the reconstruction, again, I'll just highlight a couple sites. Buccal mucosa, we typically would reconstruct these with a soft tissue flap, whether it's a radial forearm, as here, because of the thinness of that flap option. It allows you to carry out these reconstruction with minimal morbidity, but allowing the patients to have good opening and a decent quality of life. In terms of the floor of the mouth, again, typically you either can skin graft this, but more often than not, we will use, again, a thin flap such as the radial to reconstruct that and maintain the mobility of the tongue so that you preserve the speech. And it also allows, because of the thinness of that flap, the possibility to put dental implants and patients to wear prosthesis. Whenever it's tongue reconstruction, you look, again, the location, the size, and the volume to discern or to decide whether you're going to use a particular flap for one versus the other. Common is, again, the radial or another perforator flap. The idea of these reconstruction is that you maintain the shapes of the tongue, you maintain the mobility of the tongue, as you can see here, so that the patient can speak and swallow without evidence that they've had the resection. There are lots of literature in terms of how one can shape and maintain these things, or whether you do what's called a beaver tail to allow you to reconstruct the tongue, as you can see, both in volume as well as in the shape. I like to extend it anteriorly slightly and curve it underneath such that you maintain the mobility. For patients that need more volume, the anterolateral tie is a good one, particularly if you need a total tongue reconstruction. As you can see here, inset, and allows you nice mobility of the tongue that the patient can wear dentures in these cases with good function. If you have patients that need both a total tongue as well as laryngectomy, then you also can think about those larger flaps that allows you to reconstruct both the pharynx as well as the tongue in one go. And now to finish in the next 5 minutes or so, I'll just quickly go over those patients. Once you carry out your intervention, who needs adjuvant therapy in terms of radiation or radiation and chemotherapy. In terms of radiation, usually we do it as an adjuvant, but there's lots of reasons why one may deliver radiotherapy. It could be curative radiation, so primary. You can do palliative radiation for those patients who no longer are a surgical candidate or with likelihood of cure. The types of radiation, again, we know that based on the replication of those cells, they're going to be more susceptible for radiation versus not. And then there's always the continued balance between tumor control and complication, and we know that that's directly related to the dosage. So if you have complications, you can see around 5% if you go 65 gray, but the minute you go above 70 gray, you can see that those patients, at least half of those patients will have some complication. And typically the ones that we worry about are osteoarthritis necrosis, skin necrosis, and so on. Now, how you deliver the radiotherapy is important as well for us to understand, particularly from the surgical perspective. The typical is you look in both the dosage as well as the timing. The conventional is 200 centigrade per day, as you can see here, divided in those 6 weeks. If you do hyperfractionation, then you're going to diminish in the dosage, but you increase the time. So you have it's 115 centigrade 2 times per day, and then you have the accelerated fractionation as you can see here, between 150 to 200 2 times per day. There are multiple ways to deliver the radiotherapy. I think the thing to keep in mind is that now with intensity modulated radiotherapy, that you're able to conform your doses, as you can see here on the second image, that it allows you to have a better contour of the areas that you want to deliver the radiation to, while minimizing the damage to important structures. In the case, you can minimize the dosage to the spine. You can conform the radiation so that you can avoid the parotid, potentially the bone structures if you don't need to. And what does that mean? It means that you diminish the probability of having those complications to those structures that you don't need to radiate. Again, this is looking at the IMRT in terms of comparing that with conventional, or what used to be conventional. There is labor intensive in terms of delivering radiotherapy. We know that patients have to have their masks done. They have to be in a certain position. They have to have these collimators, and the whole process is quite costly and labor intensive. This is our setup in university. There are multiple gantries, but this is a typical gantry that the patient lays down, and then the gantry rotates around the patient. We also have the use of the proton, and the proton does take the advantage of this process called the Bragg peak effect, that it allows the delivery of the entire dose to one area without further extension behind that depth, which then minimizes the injury to those tissues beyond that area. So this is used in head and neck, primarily for chordomas, for some of the other sites, but it's certainly commonplace for prostate. Now, what we cannot forget is that radiation does cause some damage, and this is a friend of mine whom I had operated and went on to receive radiotherapy, and you can see that the skin damage is significant. And it accumulates. Thankfully, patients do, after this, they tend to respond and then heal. But we mustn't forget that when we do go back, if we need to go back for surgery, that this is certainly a damaged area, and we have to counsel the patients that they can expect complications. And I tell all the patients that have been radiated, if I'm operating on them, that they can expect at least a 50% likelihood of having some sort of wound complication, whether it's erythema, persistent edema, or dehiscence. And I think if you tell them this in advance, I think they're much better able to deal with mentally. We know in terms of the early effects of radiotherapy, the typical things that we see. What we do dread is the late effect in terms of the osteorative necrosis, the instability to the skin, as you can see here. And ORN, although we tend to think mostly on the mandible, but it can extend to any bone that has been radiated. Certainly the skull is one that unfortunately we have to deal with pretty frequent. And this is, again, multiple things that we keep in mind in terms of extrusions of our recon plate, and some of these patients that have not had bony recon and go on to receive radiation, that becomes a problem that you have to deal with. The risk of developing osteoarthritis necrosis is often discussed, and then there's multiple literature trying to discern what patients are more at risk, one versus the other, and then and equally in terms of how you manage that, whether you use HBO or not. This is part from the Liverpool group that saw a little benefit of using hyperbaric oxygen. There's been the Cochrane study, again, looking in terms of the overall use of radiotherapy, of hyperbaric oxygen for these patient population, and concluded that there's very low body of evidence to recommend such, and there's a lot of bias in the literature, as we all know. If you do decide to put implants, dental implants on these patients, what are the probability of these implants surviving in face of radiated patients? No, if you do hyperbaric versus no hyperbaric, is not statistically different. And lastly, how should you manage the patients that do have osteoarthritic necrosis? This is from Ed Rodriguez's group when he was in Baltimore, and the conclusion, at least from his paper here and their experience in Baltimore, that when you compare the patients that had a free tissue transfer versus the ones that had multiple little intervention, it was more cost effective to go for free tissue transfer from the outset as opposed to having these multiple interventions and then finally going on to the free tissue transfer. In terms of cost, this is the cost difference, but the patient does benefit from not having multiple intervention and also skipping the hyperbaric. So if you combine the hyperbaric plus the all of these other things compared to the free tissue transfer. So I know that I went over a bit in terms of this. Hopefully I'll make it up in the second presentation. I'm not sure if you guys want to do Q&A right now for this session or simply to go on for mandibular reconstruction. So I'll wait for your instruction.